Good morning, everyone, or at least it's morning from where I'm calling in Nashville, Tennessee. It's good to see everyone. I know we'll have people continue to filter in, but we're going to go ahead and get started as we're right at the top of the hour. Today, we're going to be talking about happy, healthy children in shelter and in supportive housing. And this is the third of a three-part learning series that we've been doing, specifically that we offered primarily to family shelters in the state of Tennessee. And then we had a few others that we invited as well. But our hope was to keep these sessions small with the desire to be able to learn from each other and to have some communication. I know that's tricky to make sessions interactive when we think about a virtual setting and not seeing each other face to face, but that's our desire. So I would encourage you, even as I'm getting started here, to think about what you've done, what you've tried, what's worked, what hasn't, what kind of challenges you face as you think about keeping the children in your program healthy, whether they're in shelter or just coming there to receive services. And these sessions have been brought to you by the National Healthcare for the Homeless Council. I'm the Director of Community Engagement there. If you're not familiar with the council, I would encourage you to go to our website. You can see it there at the end of my email address, nhchc.org. We do research, advocacy, policy work, training, technical assistance, all kinds of things at the intersection of healthcare and homelessness. And while our primary audience there is usually health centers, we have a lot of information that would be helpful to shelters as well. And we are providing this training in conjunction with a grant from the Bureau of TennCare. And it is really TennCare's desire to support families experiencing homelessness and to ensure that they can enroll in TennCare and that they can access it. And so if there's anything that we can do to help families enroll, to help families that may not be able to figure out how to use TennCare or have been dropped for some reason, or even individuals that aren't eligible for TennCare that are struggling because of health needs and need assistance in finding care, please feel free to reach out to us. We also do trainings like this for free in the state of Tennessee around any issues around healthcare and homelessness. So you see my email address there. Please feel free to reach out, and then do think about, as we're going to ask questions, how you can interact and make this more of an interactive session. We can kind of learn from each other today. Let's see. I'm going to change my view here so that I can see the screen. There we go. My background is primarily in direct support. I worked in a domestic violence shelter for several years. I worked in children's ministry in a church for many, many years. And I've worked in detox and drug treatment and working with families where mom's coming out of incarceration. And I've had this sentence hanging in my office at times over the years: first, do no harm. I really think about this as we think about children, especially in shelter. I remember distinctly several years ago, I had a little boy in my office. His name was Peter, and Peter and his mom had just come to shelter. It was a domestic violence shelter, and they had unfortunately come right as we had just a really significant lice outbreak, and almost all of the children in shelter had lice. And so Peter was, I had a tarp down in my office with a metal chair, and I was picking lice out of Peter's hair, and his mom was treating herself and getting someone else to pick lice out of her hair. And it was one of those days, you know. But I was sitting there with Peter, and Peter looked over at my desk and he saw my cell phone, and he picked up my cell phone and he opened the drawer and he dropped my cell phone in the drawer and he shut it. And he said, "You have to lock up your cell phone or the bad guys come in with guns, they'll take it." And the reason that made a big impact on me is because Peter had come to shelter from really a significantly stable family. He was about 4 or 5 years old. He'd lived with his mom and his grandmom his entire life. His mom had just recently remarried about 6 months ago, and his mom and stepdad had just had the worst fight they'd ever had. It was very unusual for them. They just had a huge fight, and things got out of control, and his stepdad just completely lost control and started throwing things and threw something and hit Peter's mom in the head. And it was a bad wound. And in the midst of the screaming and everything, the police had been called by the neighbors. And so the neighbors had come and picked up Peter's stepmom. Peter wasn't even in the house, and she ended up in shelter. I think she was probably there for a week before they figured out, okay, we're going to be okay. What are we going to do? But Peter had never witnessed any violence. No one had ever come into Peter's home with a gun. Peter had never seen a gun. He had not even been there the night it happened. But Peter's roommate, or so the family in the room next to Peter, Joseph, who was 8 years old, Joseph had grown up in a family where both of his parents were involved in the gang. And he had seen drive-by shootings. He had had multiple times where people had come into his home with guns And Joseph told all of us regularly that we needed to put our cell phones in the drawer. So Peter had been in shelter for probably 3 days, and he was covered in head lice, and he was hiding cell phones from masked gunmen. I think it made a big impact on me because I had been trying so hard with everything in my being to create this environment in shelter that was compassionate and nurturing and healing, and where children could come and feel safe and feel loved. And in all of my work to do that, Peter had come to shelter, and his entire sense of security and predictability and safety had been shaken, and he was covered in lice. He was actually less healthy for his time in shelter. And as I think about this topic that we're going to talk about today, and really working hard to keep children physically and emotionally healthy in shelter, that's the paradox we face, is that all of us in the work that we're doing, we're trying to create this really nurturing, healthy, healing environment. And yet by very nature of the fact that we are attracting and drawing in people who are unhealthy and who have been traumatized and are suffering and are scared, that as we bring the very people that we're serving into this environment that we're trying to create, the environment is compromised. And so there's this terrible paradox, especially with children in shelter, of how do we keep them healthy? How do we promote health? While at the same time, there are so many factors that by very nature of what we're doing are unhealthy. And so I want to start off today by really just kind of claiming that paradox. And that's kind of what we're going to jump into today. And what we're going to have to think about is, how do we create an environment that's healthy, that's nurturing as much as possible, when in fact we're talking about a demographic of people who really struggle to prioritize their health, who really struggle with health. And that's what we're going to talk about today as we talk about physical health and emotional health in the context of a family shelter. So this is kind of our agenda. This is the path we're going to take. We're going to talk about some common physical health issues that children face in shelter. We're going to talk about what we can do to prevent those, and what we can do to treat those, or to create an environment where families are able to seek treatment. I know we're talking today about shelter and about supportive housing, rapid rehousing, permanent supportive housing. So we're not talking about treatment as far as from a clinical standpoint, but what can we do to ensure that the families we're serving can find treatment, know what to do. We're going to do the same thing with common behavioral health issues or emotional health issues. We're going to look at some of the things that children living in a community living environment struggle with, what we can do to prevent those, what we can do to treat those. And then we're going to look at some real threats within the community living environment, within the homeless services environment, threats to children. And some of those things we can really address, and some we can't, but we at least want to name them and be aware of them, and have them on our radar. We're going to talk about red flags of signs that children may be in really dangerous situation, less common, less obvious signs of physical, emotional, or sexual abuse. And then we're going to talk about some things for us to focus on. So as you can see, we're going to be talking about some fairly difficult, some fairly unpleasant things. I just want to give you a heads up as we move into the conversation. We are going to be doing sort of a bird's eye view of those. We're going to be talking about them fairly academically and honestly fairly quickly. So my hope is that this isn't an emotionally heavy or emotionally triggering kind of conversation, but I do want to give you a heads up that we're going to be talking about some fairly unpleasant things. As we move forward, like I said, this training is funded by the Bureau of TennCare, and TennCare is really curious to know if the children that we're serving are able to access TennCare. So we're going to start off today by doing just a really quick poll. This will be completely anonymous. I'm going to share the results of this poll with TennCare, but no names, no agency names, no details whatsoever will be shared. And if you don't know the answers to these questions, that's fine as too. I'm just required to ask. So Brandon, if you can pull up the poll, and we don't even necessarily need to see the results or anything. We're just going to gather this information so that I can meet my deliverables with our TennCare grant. So how many children are in your program? How many children is your program currently serving? And again, I understand that this is an estimate, is our first question. The second question is, how many children in your program are enrolled in Medicaid? So if you are in the state of Tennessee, that's TennCare, but if you're in another state, that it will have a different name. It's named something different in every state. And then how many children in your program visited a doctor of any kind for any reason in the last 3 months? And so I'm really looking for a well child visit, whether it was with a pediatrician, a nurse practitioner, health department, something like that. And then, or if it was a sick child visit. So we're not really necessarily looking for counselors, therapists, kinds of things, but a well child visit or a sick child visit. And again, I understand those may be guesses, and that is fine as well. All right, we can go ahead and close that out. I know we have some people on the call who are not necessarily working in a family shelter and may not have that information. So I'm not necessarily looking for every single person to respond. Thank you so much for your participation in that. And as I said, I really do hope that you will continue to participate either through the chat or by unmuting as we move forward. So if you think of something, I'm going to have a few times where I ask questions, but I would really like us to learn from each other and to see what you're doing and how these issues how you've seen these issues kind of play out in your program. So first, again, we're talking about children experiencing homelessness, and primarily we're talking about children experiencing homelessness in the context of the shelter. So we're not looking at as much here as children who are unsheltered, living in a place not suitable for human habitation, living in their car, doubling up, couch surfing, although a lot of what we're talking about will apply to that as well. So this is these are some statistics from our website, and also you'll see the other link there. But we know for a fact that children are not as well when they're homeless. You might think that might be kind of an obvious thing. I would certainly think it would be obvious when it comes to behavioral health and emotional health, but homelessness, poverty, crisis affects the physical health and development of children. Children who are homeless for more than 6 months are at higher risk for poor health outcomes. The longer the experience of homelessness, the greater the risk. We know that children experiencing homelessness, and again, most of this research you're going to see across the board is conducted in shelters. Respiratory infections 4 times as often, ear infections twice as often as children who are housed. Gastrointestinal problems 5 times as often, 4 times more likely to have asthma, and they are at a higher risk for obesity. And for all of these illnesses, children experiencing homelessness are significantly more likely to seek treatment in the emergency department than they are in a pediatrician's office, which means the consistency of care, the long-term sort of scope of care that you would hope to see with children, especially young children, is very often not there. So when you think about a chronic condition like asthma being treated in the emergency department, as opposed to being treated by a family doctor, a trusted pediatrician, there's a significant difference in the kind of care, the level of care that a child receives. And yet we see almost across the board, homeless children are so much more likely to go to an emergency department for healthcare. In addition to the things that we just talked about, these are also things, I don't know about you, but for me, these were the things that, these were the words that just sent our shelters, the places that I've worked, into absolute convulsions. You know, the whole place fell apart if one of these words was mentioned. COVID-19 was not an issue when I was working in shelter. I've been visiting shelters and working with shelters throughout the pandemic, and so I know it's even worse. I was working in the shelter system when H1N1 was a problem, and we had some residents who died from H1N1. It was a big deal, but the community did not respond to H1N1 the way they did to COVID-19. And so even though it was really dangerous, especially in community living, we did not have to worry about what's the health department going to do. We didn't have to think about quarantine periods, or some of that probably would have helped. Some of that was certainly easier because we didn't have to think about all of that. But these are the kinds of things that we just see come through shelter all the time, and certainly at a significantly higher rate than you would experience in your own home. What other kinds of health issues have you seen in shelter? So you'll have to unmute to be heard, or you can put it in the chat. But what kinds of illnesses, infections, disease, what kinds of things do you see the children in your programs just struggling with all the time? Do you find that the children in your program do tend to be unhealthy, or do you find that these things aren't really an issue? All right,
Quick,
well, I will move forward. Go ahead.
oh, thank you. Quick question.
Mhm.
Would it matter if it's not children? Because I know that in my prior shelter, at least at a PRK, bed bugs was fairly commonplace, and it actually got so bad at one point that it spread from one individual to another because folks weren't following the protocol and hotboxing those items. So it was a very unfortunate thing.
Yeah, absolutely. And bed bugs are just, I was at a shelter last week where they had just had an outbreak of bed bugs. And yeah, very much like you mentioned, they had guidelines in place that would have probably kept all of that really under control. But how do you enforce that? And yeah, bed bugs is one that I think just devastates devastates shelters, can be so hard to get rid of. So yeah, absolutely. Anyone else? Again, I fully recognize the awkwardness of, of engaging in a virtual setting. So I'm happy for everyone just to listen as well. What's important to me is that we share valuable information. And so if you think of something that you'd like to add, feel free to add it in the chat, but we will continue to move forward. But yes, these are the kinds of things that that can be controlled, and what's also interesting about these things is none of these things, with the exception of influenza and COVID, none of these things are really life-threatening. There can certainly be exceptions where some sort of bloodborne pathogen's been spread or something. They're just incredibly annoying, and they just add so much stress and tension and frustration in shelter. And your volunteers don't want to come, and staff want to quit, and people are fighting each other and suspicious of each other. And so, yeah, these are the kinds of things that just make shelter a much harder place to be. But especially in programs where we're serving children, we see, because it is very difficult to somehow require a toddler to conform to certain policies and procedures, that these things can just really run amok. And like with things like scabies and bed bugs, you can think that it's over, you can think that you've taken care of it, and 6 months later you find out, nope, it's still here and it never went away. And so absolutely, these things are certainly major health issues. So as we think about the significant things that we talked about in the previous slide, like asthma and gastrointestinal issues, and even things like influenza, it's interesting to think about why are children at greater risk in a shelter. And certainly, if you've ever sent your little tyke off to preschool or to their first day of kindergarten, you've learned as a parent what it's like to have your child suddenly surrounded by other children. So we get that. We certainly understand that just by nature of being around other people, the likelihood of infectious disease and the spread of infectious disease is more significant. Of course, we all know that after the last 2 years we've lived with the pandemic. However, 4 times more likely for gastrointestinal issues, 4 times more likely in some states for asthma. There's a 60% increase in the number of homeless children who are diagnosed with asthma in some states. And they're not states where you would consider that to be an environmental issue. Certainly the physical living conditions can be a factor, and just the sense of community can be a factor, but these are significant statistics. And so it's a little bit puzzling to understand exactly. There's not a real clear, direct medical correlation or medical explanation for why children in poverty, children in crisis, really, children experiencing acute stress are more likely to have significant physical symptoms. It just seems to sort of be a reality that children, when they're under significant stress, that can be displayed through things like a chronic runny nose and through things like a chronic cough. So physical living conditions can be a factor there. And that's what we're going to talk about, is some of the things that we can do in shelter and in supportive housing to try to eliminate those factors. Dehydration and nutrition are also significant factors. We find that a lot of children who visit the pediatrician who are living in shelter are frequently told that they're dehydrated. There could be a lot of factors for that, but it certainly could be that how easy is it for a child in your program to regularly get a drink, to regularly have access to drinks. We know a lot of shelters, the kitchen can be closed. We know a lot of shelters, you're not allowed to have food or drink, or maybe just not the kind of food or drink the child would prefer in their room. And so there can be things that we do, and we're going to talk more about this, that actually make it harder for a child to stay healthy and hydrated. Exposure, certainly children experiencing homelessness may be outside more in extreme weather. Sleep deprivation is another big factor of shelter life. Very often children are not able to get the sleep that they need. That may be because of shelter requirements. It may be because of the number of people in the room. It may be they just don't feel safe. It's just not quiet is sometimes a big factor for children in shelter. A lack of physical exercise. If children are really kind of staying in their room and aren't able to really be active, it may be that in the shelter, they're just not allowed to run or climb. And certainly I understand that, but that does limit their ability to exercise if they really are expected to kind of stay still, stay in your room, stay in your bunk kind of thing. A lack of privacy. So the inability to keep their personal belongings with them and clean and safe, that if everything that they own is constantly exposed to a lot of people. And then there is a lot of thought, although I don't think you're going to find concrete medical evidence to show this, that a lack of consistency and a lack of stability can certainly aligns closely with a poor physical health. And so as we think about babies, young children, even school-age children, but especially when they're very young, who are constantly passed from person to person, they don't have a consistent caregiver. They may have vastly varying schedules as a result, and especially for an infant, for a toddler, we know that can have a lot of impact on them. So there's a lot that goes into a child's health beyond just, they're sleeping in a place far from home, or beyond just they're with a lot of kids. There are a lot of other factors that go into physical health. And if we can kind of keep these in mind as we think about encouraging a healthy environment with children, I think that will be really helpful. So let's talk about what we can do as an agency now on our end. We know there are things that the family can do, and we're going to talk some about that, but what can we do on our end to make shelter a place that is healthy, or at least, again, where we're not doing harm, or we're not spreading germs, we're not spreading infection? What can we do on our end? According to the CDC, the number one way to prevent illness, and this is the number one way to prevent illness in a community living environment, is to wash your hands. I've done this training for years, and when I did this training 6 years ago, and I would show this slide, people would go, really? Number one thing is to wash your hands. But I think probably coming out of the pandemic, and we've seen especially initially, such an emphasis on hand washing, I think this probably is a much more common idea. So as we think about washing your hands, though, how easy is it for a child in your program to frequently wash their hands with warm water and soap? So I worked in a program where if a child was outside, was sitting with mom in the smoking area, right, which is a totally different issue with health. But if a child was sitting outside by the door in the smoking area waiting for mom, and they had a monster sneeze, right, just it went everywhere, big old sneeze, now I need to wash my hands. They had to go to the door and push the button. And when they pushed the button, staff would come over the intercom and say, what's the security word? Most children were not able, if they'll say they were too young to read the security word, or they forgot it, then they would have to go back to mom and say, what's the security word? Go back, push the button again, say the security word. Then they could come into the building. Once they came into the building, they had to go, the nearest bathroom would have been the kitchen. The kitchen may or may not be locked, depending on the time of day. If the kitchen was locked, then they had to go up the stairs around to their room, assuming that they had the key and they were able to use the key. If they went into the kitchen, they had one big door to go through, which most of them would not have been able to open on their own. They had to go through the dining room, through the kitchen, to the back bathroom. Once they got there, another big door, which most young children would not have been able to open on their own. Once they got into the bathroom, they're in a community bathroom, which may or may not have soap. The paper towel holder would have been too hard for them to reach. About half the sinks, the hot water or the cold water, one or the other, didn't work. And so children were pretty hesitant to turn it on because they could get burned. As you can see, there were a lot of barriers between sneezy child who needs to wash their hands and the nearest sink. The same things that we did to encourage security actually made it, harder for a child to get to the bathroom to wash their hands. And so, of course, for that reason, kids didn't wash their hands very often. And so a really helpful thing to do can be to look at your program and say, how easy is it for a kid to wash their hands? If I'm 4 years old, what does the bathroom look like to me? Can I reach anything? Can I reach paper towels? Can I get the soap? Do I know how to use the soap? Can I turn things on? Can I turn them off? These are all really important questions as you think about just simply washing your hands. And if there are barriers like there were in that shelter that I really can't do anything about, it's a high security shelter, what am I going to do to mitigate that? What am I going to do so that we don't have so many barriers in the way that prevent kids from washing their hands? Would you use the bathroom that the children in your program use? I remember where I was and what I was wearing the first time I was challenged with this question. We were doing, this is just almost shameful to say, but we had a new group of a new volunteer, and I was giving a volunteer a tour of a program that I worked in. And I said, this is the staff bathroom over here. And then as I was doing the tour, I said, no, this is the guest bathroom over here. And she said, okay, well, I'm just going to slip in and use the bathroom. And I said, oh, I wouldn't use that bathroom. And she said, well, why not? And I said, that's the bathroom that's reserved for guests. And she said, so you wouldn't use the bathroom that you expect all the guests to use? It's a very challenging question for me. And I find that every time I ask that question to shelter staff, I've actually in one training had someone stand up and get really animated about this question. But I've been to programs where the bathroom honestly was the place where illegal drug use was most likely occurring, if it was occurring somewhere, where the bathroom was the resident bathroom was the place where you were most likely to find drug paraphernalia, where you were most likely to find dangerous, illegal things happening. It was very often in disrepair. It was very often not well stocked because staff didn't go in there. Same thing with the kitchen. If there's a part of your program where staff never go, more than likely that's going to inform the safety, the level of the culture of health in that part of the building. And so, so just some things to think about as you think about your program and the health of those who stay there. How difficult is it to wash your hands? How do you feel like the bathrooms are safe places where people don't mind regularly going to wash their hands? Just some questions to think about as you kind of process this information. So again, much of this is advice from the Centers for Disease Control that having these different items or considering the sanitation of these particular items can be huge in preventing the spread of contagious disease. Now, I say all these things, and I know, again, these are hard things in shelter. Simple things in our homes, simple things in much of society, but difficult things in shelter. I cannot tell you how many times I would go into the playroom in the shelter where I worked, and tissues would just be everywhere because someone had just picked up the box and just pulled out every single tissue. But the reality is, the presence of facial tissues, the presence of toilet paper, again, being able to easily get to these things, easily accessible, does fight the spread of disease. Because if you don't have these things, especially with children, then other items are being used, right? Then the couch, the countertop, the carpet, these things are being used as tissues and potentially as toilet paper. So having these things accessible, according to the CDC, is a viable way of spreading, of creating a healthier environment. So having facial tissues, having toilet paper, and then having an easily accessible trash can where these items can be thrown away, where they can be disposed of, and having them all over the building where people are easily able to access them if possible. Hand sanitizer as well. Hand sanitizer will work as well as washing your hands, but we know in a lot of programs there are challenges around hand sanitizer. I have had children who tried to ingest hand sanitizer, and I've had many times clients with alcohol use disorder who ingested or inserted large amounts of hand sanitizer. So you have to determine based on your program, is that safe? But that certainly will help to limit the spread of disease. Having trash cans that are accessible. Again, if you have tissues, but you don't have trash cans, then you're kind of still just spreading the same idea. And trash that is with liners that are regularly emptied and replaced with clean liners. This again is a recommendation of the CDC for community living environments. That would be in resident rooms, in bathrooms, all throughout the building. The trash cans are easily accessible. One of the ways that gastrointestinal issues especially, but also certain types of parasites, worms, kinds of things are spread are through inappropriate use, inappropriate diapering in community living environments. And again, for those of you that work in a shelter, this is just, you see this every day, right? Babies on the kitchen counter having its diaper changed, babies on the sofa, babies on the floor, babies, just babies being changed everywhere. I've had clients move stuff off my desk and put baby down and change their diaper. And yet this is a significant way in family shelters that disease is spread. So again, it may or may not be possible to have diapering stations that are regularly sanitized, wiped off, but where baby can be changed and where baby can't be changed, how to enforce all of that, I realize I do not say that lightly, but getting that under control will help with the spread of infectious disease. That one specifically, there was research done, and I didn't quote the study, and so I'm just kind of throwing it out there, but there was research done where a team went into different shelters in New York and looked for, with special lights and stuff, looked for the places where there was the most significant collection of bacteria disease, and it was almost all around places where diapers were being changed that were inappropriate. So something to think about as you think about the layout of your shelter. Also, more thoughts for your agency on how to stop the spread of disease within your agency. Dishwashing. This one is huge. So many programs where you have a communal kitchen, or maybe even just a kitchen that's being shared by just a couple of people or a couple of families, and the dishes are not washed properly. This very often means that there's a dishwasher, people load the dishwasher, but they don't run it. And the next family comes in and they take dishes out of the dishwasher and they assume that they're clean. This is a huge issue in community living. Or where you have dishwashers where the average resident does not know how to work the dishwasher. Maybe it's an industrial size or something tricky, or they've just never had one. But this is a big way that the germs are spread in a community living environment. Is there some way that clients adhere to where they make sure that dishes are clean, that the dishes they're eating off of have been properly cleaned at the right temperature with soap? Same thing with laundry. A lot of times a laundry will not be done, or it will not be done properly. It won't be done with the right temperature of water or the right temperature of heat in the dryer. And so as a result, it's just like wearing dirty clothes. It's just like wearing dirty sheets. This is true for clothes, sheets, towels, things like stuffed animals, coats, and blankets that we think about with children. If these things are not washed properly, then certainly this is a way that disease can spread. And so it's difficult to know, how do we mandate that? This is a big issue. We want to have a trauma-informed environment. It's not very trauma-informed if I'm walking up to people and saying, hey, have you washed your clothes? I think your socks are dirty. Why do your sheets smell? No one wants to do that, right? We don't want to be those people. And so thinking through as an agency, how do we ensure, as to whatever degree is possible, that things are clean, that things are washed, without walking around all the time shaming people and actually even kicking people out because they didn't have good hygiene. And so that's again, there's that paradox. How do we do both? So stopping and thinking, and again, some of this you may have done more than typical, especially this time last year or last spring. Excuse me. But what is never washed in your program, or what is rarely washed? In the programs I've worked in, that was things like sofas, carpets, toys. We had a routine for even things like doorknobs usually, but there were certain things that, that we would have had to pay someone to come in and clean, or they had to be steam cleaned, or because of the material they were made out of, they just never got washed. And so developing a plan to ensure that every speck in your program is regularly sanitized and cleaned. Obviously, things like doorknobs and kitchen counters and toilets and bathroom counters, we would want to have cleaned very regularly. But even the things in your programs like strollers and playpens and changing tables, a plan to make sure that, especially between families, all of that is sanitized. And then to eliminate as much as possible those items in your program that can't be washed. And that's difficult with children. It's really difficult with children to think about only having toys that can be washed, but something to think about as you think about your agency overall, really thinking about how do we make sure everything is cleaned at some point. Now let's talk about, we talked about from the agency side, what can we do on our end to prevent the spread of contagious disease? Now let's talk about what can the family do? What can we do to encourage the family to prioritize health? And that's really a big part of what we're battling here, is that when you're in crisis, when you're in survival mode, you're not really thinking so much about, yeah, but has the comforter been washed, right? It's not in the top 25 things that have to be done. And so now your staff may be thinking that way. And this is a big issue that we face when we talk about creating a health, encouraging health in shelter, is that your staff may be walking around going, oh my gosh, they've got scabies. Did you hear that? They've got scabies in room 4. What are we going to do? Scabies in room 4. And for your staff, it may be a crisis. But for the family in room 4, they'd be like, who cares? We don't know where we're going to sleep tomorrow. We don't know how we're going to buy groceries. I don't know how I'm going to get the black shoes I have to have for the job that I just got. And I don't know what we're going to do with the kids when I try to get there. And so with physical health, there can be a lot of tension and frustration and anger and fear, because what's really a crisis for your staff and your volunteers may just be one in a long list of disasters that your residents are facing. And certainly for the children in your program that are in no way prioritizing, well, is everything sanitary? Is everything sterile? So you really have to be aware of that at all times when you're thinking about stopping the spread of infectious disease. That what is a 5-alarm fire for you and your staff? Like, I'm going to quit if somebody doesn't do something about the scabies. Man, it just may not matter at all to the family in crisis. So how do you balance that? How do you honor the family and what they're going through in a trauma-informed way, in a compassionate way, but also address the issue in a way that your staff don't quit and that everyone on your team doesn't have scabies, right? So that's where you have to kind of find this balance. When we think about mandating hygiene, these are all things to take into consideration. Certainly you want to have some sort of guideline around making sure that dishes are washed and that we don't have food all over the building and we're attracting vermin, and at the same time balancing that this 3-year-old may not go to sleep unless they can hold a vanilla wafer in their hand, right? So taking all of that into consideration can be really challenging, and keeping all of the different factors in mind. But how do we mandate good hygiene? Certainly between families, as residents, as one resident leaves and another resident comes to the room or comes to the housing unit, but also as we think about common areas, how do we encourage families to do their part, to keep things clean, to fight the spread of infectious disease without making it impossible to live there. And we just can't stay here because we can't even complete our program because we have to be so focused on cleaning up. And I have seen shelters like that, where the list of chores that every client has to do, in addition to working their job, in addition to picking their kids up from school and getting the homework done, the list of chores mandated by the shelter makes it almost impossible to look for housing or to go to group or to do the therapeutic things that the program is really primarily designed to offer. So keeping all of that in mind. So we can certainly talk about things and address these things in community meetings and prioritize these things as much as possible when we have everyone together. A lot of programs really try to use posters and things like that, as opposed to people feeling lectured. There can be a lot of benefit in that if people read them, if you can keep them on the wall, things like that. But making those conversations a regular part of community meetings and what's going on around. These are also things that can be talked about in one-on-one and can be incorporated into case management. I think most case managers, on their checklist of things that we have to talk about and do, talk about bathing probably isn't on there. So, just make that part of what, sorry, my husband's decided to text right now. Make that part of what we talk about is how can we keep everyone clean? How can we keep everyone, especially from a safety perspective? I also find with families that couching this conversation in the light of everything that you're doing to take care of your children, this is part of being a good mom. I know you're an excellent mom. Just want to make sure, getting clothes washed, stuff like that. I know it's hard, but I know you're doing everything you can to take care of your kids. And your kids are really important to you, and you're getting that done. Positive reinforcement as opposed to, why are your kids so dirty? Everyone says your kids smell. How can we make this part of what you're trying to do to take care of your kids? A lot of this really comes down to families really aren't prioritizing their health when they're in crisis. Completely understandable. So how do we make that one of the important things that families are considering? We know you're really trying to get a job. We know you're really trying, to get disability benefits. We know you're doing everything you can to check off the list from your probation officer. Just how do we also make sure you're keeping the kids healthy? How do we also make sure we're keeping you healthy? A lot of what we do with our health is directly tied to our sense of self-worth. And so when you're dealing with families where the parents or the children, the youth don't have a strong sense of self-worth, then they're probably not going to prioritize taking care of themselves, right? It's like your car. If you have a really nice car, you go and you get the super expensive car wash and you got the special car shampoo and the Buffy thing, all of that. I don't have a really nice car. And so I don't spend a lot of money on all that. I don't think it's worth a whole lot. So I don't invest a whole lot in it. Same thing with your health. If you've got families that have just really lost a sense of worth, they just feel like we're losing, we're failing, then very often their health will suffer as well. They're not going to prioritize taking care of themselves. So how do you increase that sense of worth, that sense of I'm important, that sense of I want to make this work, I want to take care of my children, I want to take care of myself? All of that's tied in with shame and self-worth. And so sometimes you have to really address those underlying issues before something like health will be a priority. Encouraging well child visits, vaccinations, sick child visits. And I do see that there's been a lack of emphasis on this as shelters embrace a housing first model. I'm all for a housing first model. I don't have any problem with that. Just like anything, there are pros and cons. And one of the disadvantages of a housing first model in a lot of shelters is that shelter staff will say, all right, let's get you into housing. And when you get into housing, then you can get your vaccinations, then you can get the kids to the doctor, then you can address that asthma, whatever. And so what happens is the family gets into housing and they never do those things. And so we used to really prioritize while the child's in shelter, let's schedule that well child visit. Let's make sure they're up to date on their vaccinations. Let's do something about this cough. Let's do something about the toothache while they're here in shelter and you have all this support. And with the housing first model, really don't do that much anymore. And so we have to be really careful that we don't end up taking even really significant medical issues and saying, well, they'll take care of that when they're in housing, just get them in housing, get them in housing. Sometimes physical health issues are what make it impossible for a family to stay in housing. If mom and dad can't work because someone's always got to stay home with a child who has asthma, then it might be really good to figure out what you're going to do about the child's asthma before mom and dad get into housing and try to get a job, right? So just something to think about, not at all to push back against housing first, but just something to think about that how is this going to be addressed in the grand scheme of everything this family is trying to do. I find, of course, that a lot of parents don't want to take their child to the doctor when they're in crisis. We're going to talk a little bit more about that too. But encouraging families to push past that fear and to do what they need to do to prioritize their health. And then are we modeling good health? If I'm regularly saying things like, yeah, I need to go get that checked out, but I hate going to the doctor. If I'm making statements like that, if I'm making statements that actually belittle the prioritization of health. So really, you're going to take them to the doctor when you know you need to get a job and go and get this paperwork filled out and what you're taking them to the dentist. We can do that. We can do that without realizing it. And so we want to make sure that we're modeling the importance of this, even in our own personal lives and what we talk about with residents. And then, as I mentioned earlier, with the door situation and the child trying to get to wash their hands, it is actually possible for us to discourage families from pursuing their health unintentionally. When we set up rules like rules that make it hard for children to take their medicine, to have access to their medicine when they need to take it, when we set up rules that make it hard for families to make their own food or to eat when they need to eat, for children to eat when they need to eat, for children to eat food that they will eat. When there are things that we can do, policies and procedures that we can put in place that actually make it really hard for families to eat and sleep and play. And when we talk about children and their health, that's the most basic thing we're talking about. Children have to eat and sleep and play. And without intending to, we can have policies and procedures that make that really hard. Can't seem to eat when they want to eat, what they want to eat. They can't go to sleep for noise or lack of privacy or whatever. And they can't play. They got to be quiet, or they can't go outside. So I encourage you to look at your program again, that bird's eye view. What are we doing to encourage children, to encourage families to be able to eat and sleep and play? And then what are we doing to encourage health overall, to prioritize health? And are there things that we're doing that are making that hard? Now, again, we're talking about the shelter environment. So we're not talking about, when we talk about treatment, we're not talking about clinical treatment, but this is one of the main issues that we're called in for in our program, is to help families with Medicaid. And so we see the worst situations when it comes to families are sick, someone's sick, child is sick, and because their Medicaid or their insurance is not where it's supposed to be, the family is in absolute crisis. And I'm sure you've had days where you've come to work and thought, okay, I'm going to take the family and we're going to go sign up for EBT today, and we're going to go look at that housing, and we're going to get this application filled out. And you walk in the door and the 3-year-old has a fever of 104, it's been throwing up all night, and everything's kind of out the window. And your whole day is going to be about, what am I going to do with this child? And do they have insurance? And where do they go to the doctor? And right. And so being proactive about making sure that your families know their insurance status and know what they're going to do if someone gets sick is huge. And I see families that are in absolute crisis and who end up staying in shelter longer, or who end up losing their housing, their newly achieved housing, over health issues all the time. Where one child's in a car accident, or one child receives a diagnosis and everything is thrown off because they didn't have insurance, or because they didn't know that they had insurance, all of that. So I realize the last thing we want to do is add another step to intake. But these are really things that at some point in the first few days that you're working with a family, that's really good, just essential to get nailed down. Does the family you're working with, are they enrolled in Medicaid? And do they have their insurance card, or in any insurance? And do they have the card? Because if they don't have the card, it's as you can't call up the doctor's office and say, hey, my child's sick and I have insurance, right? You're going to need more specific information. And so do they have their insurance card? If not, how do they get it? Let's get it as soon as possible. With Medicaid here in Tennessee, that would mean going to tencareconnect.gov and asking for another card, making sure that you've applied, checking the status of your application. All of that can be done online in pretty much any state. Tennessee was the last state to literally to adopt an online portal. Do you know who your primary care provider is, and does it need to change? If your child gets sick while you're in shelter, while you're in permanent supportive housing, you've moved into housing. If your child gets sick, what are you going to do? Where are they going to go? Really want to avoid sending children to the emergency department. It's traumatizing, it's expensive, it's not where children are going to get the most consistent, reliable care. So what are you going to do? How can we get you to a pediatrician if your child gets sick? And so kind of safety planning on the front end of the first few days that you engage a family can be life-saving, literally, down the road if there's a crisis or if someone gets really sick. And then I would encourage you, as someone who's helping families with housing, to build strong relationships with local clinics and to build strong relationships with your local health department. As much as possible, to have someone there that you can call and say, hey, Everyone in shelter's got lice. Can someone come and help us? What can you recommend? Everyone here, we've got coughing and sneezing and fevers. What should we do? Can we send people to you? And developing a really smooth handoff between your shelter and local clinics, between your shelter and the health department will really benefit your families and will benefit you as well. So having someone you can call for advice, having someone on your board, all of these can be really important. All right, so that was a grand overview of physical health issues that children face in shelter and what you can do to help. We're going to talk for a few minutes about behavioral health issues. The first two episodes of this listening series were about trauma. And so we talked a lot, and the recordings are available on our website. You can actually go to our website, nhchc.org, and you'll see the link there on the front page right now. But so we talked a lot about acute stress disorder in children. We talked a lot about resiliency. I don't want to spend too much time on that now. What I do want to talk about are behavioral health issues and just sort of the same way that we talked about physical health issues. What are issues that children in shelter commonly face? What can we do to help? But we're not going to spend as much time on this because of the previous two episodes. Children experiencing homelessness and living in a community living environment, living in a shelter or in supportive housing, and that's going to vary some, have twice the rate of learning disabilities. They suffer from 3 times the rate of emotional and behavioral problems as their housed counterparts, 4 times the rate of developmental delays, and they are at a significantly increased risk for depression, anxiety, and suicidality. This, I think, is not quite as surprising, especially in light of the last 2 sessions, as the physical health issues, the very specific physical health issues like gastrointestinal issues and asthma. We can certainly understand this a little bit more. I want to talk for a minute about suicidality among children. When I first started doing this kind of work, we just never talked about suicide in children. It was just almost unheard of, very, very rare. Last year, there have been years where here in the state of, in the last, I believe it was true in 2019. I believe it was also true in 2020. I know it was true in 2018. The number 1 cause of death for children between the ages of 10 and 18 was suicide. It's unheard of. The number 1 cause of death in children is almost always accidents. And suicide would be way down the list. And there has been a dramatic increase in the number of children committing suicide. So this is something that in your training, you may have never heard addressed. It may have never been talked about. And now it is something that we talk about regularly in trainings and assessing even 10, 11, and 12-year-old children for suicidality. So definitely something to have on your radar that you may not have had it on your radar if you've been doing this work for a long time. One of the significant contributing factors to that is believed to be social media and understanding the role of social media in the children that you serve. And that's a different training. It's a big topic. But that is certainly the fact that if I do something foolish or something silly, not only do the 10 people in my class see it, but thousands of people could see it and what that does for a child. And so certainly something to think about as you think about the culture and dynamic of your shelter. And that's something that you may have months in your shelter and it's not an issue at all. And then you may all of a sudden in your shelter, it's a huge issue and everyone's, using social media. So it's something that you kind of have to be aware of it as it may kind of wax and wane, especially among your children and youth. So we've talked about these things somewhat in the last 2 sessions, but encouraging self-expression. Self-expression is something that is a real issue with children in crisis. Am I saying what I like, what I want, my favorite color, my favorite food? Am I reestablishing verbally through art, through play, who I am? I am someone. I am here. I exist, and I'm unique. And children in trauma tend to close in, tend to shut down. They may be aggressive, but even in that aggressive nature, they're not expressing themselves, right? They're just venting. It's just raw emotion. So lots of ways that a child can express themselves. And I'll be honest, in a lot of programs, this is actually, again, this is one of those places where we can actually discourage healthy behavior. Because in a lot of programs, we just need the children to be quiet, to be where you're supposed to be, eat your food, go to bed, go to school. And the children being there and expressing themselves is a terrible burden, right? It sounds terrible, but it's very often true, where we just need you to stay with mom, do what she says, stay in your room, stay in the bunk room, stay on the playground. But children everywhere expressing themselves would just be a disaster. And so we would never say that, but that can very often be the case. So what can we do with our staff that are less child friendly? What can we do to really stress the value of talking to the children in our program and engaging them and finding out who they are and giving them place where they can speak and be and express themselves? It's a totally different mindset from very often the children in our program. It's just kind of, let's just keep them all alive, right? But encouraging personal choice and encouraging agency to create settings where feelings can be discussed and memories processed. This is the difficult thing about homelessness for a child. We talked about this before, is there's no context for a homeless shelter in a child's life. They don't see it on TV. They don't read about it in books. When they're in their classroom at school, no one else seems to have a story of a home life that coincides with what I'm experiencing. It's like they're operating in an anomaly. So creating a place where we can talk about who we are, what's happening, as much as that's possible, can be really healing for children. And again, we're talking about things here that we can do without a degree in counseling, without a therapy, without the expertise of a therapist, just creating places where children can just express who they are and just talk about what they're feeling and thinking. This is something anyone can do. This is something we can train mom and dad to do. We can model for mom and dad, right? Anyone can do this. But it can be so important in kind of normalizing the experience of the children in crisis that you're serving, offering positive, sustainable coping mechanisms. Very often children in crisis are seeing coping mechanisms modeled that are very unhealthy or that are not appropriate for them. Almost every child many children that I've served pretended to smoke because that was the primary coping mechanism being modeled to them, that when you're stressed out, you smoke. And so I would walk into the playroom and have, 7 or 8 children varying in age from 2 to 10 who were basically smoking their pen or their crayon and didn't even realize it. So what kind of coping mechanisms can we model that are sustainable for children, even when they're not in shelter? There are really good things that we can do with children in shelter, but once they're gone, they can't do it at home on their own. So, I would have children, if they were angry, rip up paper. Can you just rip up paper? Can you hit your pillow on the ground? What can you snuggle? What can you cuddle? What can you do with your body to help you cope? What can you draw or write or dance or jump? What can you do that's sustainable? I had children children who just found it extremely helpful to rock back and forth. So we had rocking chairs. Can you sit in a rocking chair? Can you sit in a recliner? It doesn't look super healthy, but it's a whole lot better than smoking or crayon, So what kinds of things can we do with our body, with our mind, that even if they're alone in an apartment all day, every day for the summer after they leave shelter, they can still do? So offering positive, sustainable coping mechanisms, even if they're not as ideal as the wonderful, shelter provided coping mechanisms that they can do in shelter, but offering both. Here's something you can do even if you're not here, even if you're in an environment with very few resources. Safety planning with children increases their sense of control. Okay, if mom and dad are fighting, where could you go in the house? Who could you talk to? What's a safe place? Is it safe under the bed? Again, these aren't the kinds of practices we would necessarily encourage in children who have a strong, supportive, healthy family. But that may be not what we're working with. So given the children that we are working with, what kind of safety plan can we help them create so that they feel powerful, they feel in control, even when bad things are happening? But when I talk to children and youth who are afraid that they're going to be put in foster care, okay, let's talk about that. What could you do if you went to live with a new family? right? I don't say to those children, oh, your mommy and daddy are never going to leave you. I don't say that. I say, okay, what are we going to do? And what would we do if you go to foster care? Let's look at what they're afraid of. If that's a possibility, then let's step into it. Let's face it. Let's accept it. Let's look at it for what it is. Okay, what could you do? What personal agency would you still have in that situation? Let's grab it. Let's go for it, right? Look for permanent sources of trust, help, and support, something beyond yourself, something that's going to be in the child's life, even when they leave your case management or they leave your office, a permanent source of help, teachers, coaches, mentoring programs, trusted family members, trusted friends, trusted sources of support, maybe online or in the community. Point them to things that are sustainable, that will give them a place that they can look to when they're feeling overwhelmed. And so encouraging the family to do this, encouraging mom and dad to do this. How can you help your child get the help they need? Encouraging family to speak, to tell their story to providers and to therapists is really important. A lot of time, this is a big issue for homeless families, is shame. And so they don't tell anyone what's happening to them. Tell your doctor what's happening. Be honest. This is where we're at. Just claim it. Just hold on to it and explain it. And don't feel like you have to hide it. Developing familial coping mechanisms, ways that the whole family can support each other and cope if that's possible. And then thinking about, is medication an answer here? A lot of shelters are really looking into the option of doing therapy in shelter. I know there's been a lot of success with that with adults. Sometimes with children, what we have to consider is, are you going to open doors in that child's heart and mind, and then they're going to disappear? And then mom's going to take them out of shelter and you're never going to see them again. So you really have to be careful about how deeply you go into past memories, into past trauma, if the reality is the child this is not a sustainable source of shelter. But we really see a lot of families who are afraid to tell their providers, to tell their teachers what's going on. And so then the children have to keep it a secret too. And so that's really something to think about. All right. A couple more things as we finish up. First, let's look at threats to physical and emotional health in shelter. Some of these we can't do anything about. I think it's still good to be aware of them and to is there anything we can do to mitigate these? We talked about this at the beginning with the story I told about Peter at the beginning. The fact is that the very nature of of a community that's comprised of people in survival mode, of people in crisis, of people who are disoriented, who are navigating extreme loss, extreme grief, very often comprised of people with severe mental illness, with substance use disorder. The very nature of that community, there'll be strengths in that community. The very nature of that community, though, can be that it's traumatizing. So what can we do to ensure, so being aware of that, and again, trying to create an environment where children are protected from that as much as possible. Unstructured playtime, times where adults and children are all just kind of mingling together. These are times where you really have to be careful. Times where there's a high tension level in the shelter and the adults and the children are all together. Times where children are playing and there's no adult present. Times like this are times where that re-traumatization is likely to occur. And so being aware of that. Having the food availability is huge for children in shelter. It is very common for children in shelter to lose weight, and sometimes a significant amount of weight. Some children will come in and gain weight. They'll just eat as a way of coping, or they may eat food that's much more high sugar, high fat than what they were used to. But a lot of children will come, and you have to really watch children that are actually just kind of wasting away because they don't like the food that's being offered to them. It doesn't taste like what we had at home, right? So being aware of that. How can you have familiar foods, even if they're not the healthiest foods? Children have to eat, adults have to eat, and so better to eat something that's not healthy for you than to eat nothing at all in the immediate, especially not necessarily long-term, but making sure that foods are available and that children are eating. Privacy, especially for children who are coping with the trauma by withdrawing. If you're trying to withdraw and they're just kids trying to play with you all the time, right? Some kids love that, some don't. So children who are introverted, who are withdrawn and cannot get even a few minutes alone, trying to create places where children can go and and have some space and have some privacy. Sleep, again, we really tried to emphasize eat, sleep, and play. Places where children can play, where they can be silly, where they can laugh, where they can be loud, where they can run, where they can climb. That is absolutely got to be part of your shelter environment. The ability to complete schoolwork, big problem for children who are homeless. If lights have to be out at a certain time, if I constantly have my siblings all over me, if the TV is always on, then I'm not going to be able to get my schoolwork done. And the ability to participate in extracurricular activities. Proximity to extended family and pets, a big part of homelessness, especially sometimes with domestic violence, is I can't be with my extended family, maybe my siblings, my grandparents, maybe my pets. How do we mitigate that? Can we write letters? Can we do Zoom calls? What can we do that's safe to engage with important people in the child support system? Exposure to dangerous substances, illegal drugs, even just cleaning supplies, always keeping that in mind. I certainly had children in shelter who were exposed or even given illegal drugs in shelter. So always being aware of that possibility, and then just the exposure to people who are unstable or at least unhelpful. Constantly trying to mitigate that and create a system that mitigates that. So here are some things that you may not think about. Children in shelter, children in crisis, very often do not say when they're sick. This is a huge issue. I've had children who almost died, especially youth, because they were so sick and they would not tell anyone. Maybe they were afraid to make mom's life harder. Maybe they were afraid they would get kicked out of shelter. We'll all have to go to a hotel if they find out I'm sick. We'll all get kicked out. We'll all get sent to some isolation place if they find out I'm sick. So creating an environment where it is safe to be sick, where it is safe to say, hey, I'm really itchy right here and I can't make it stop. But we're not going to get kicked out. We're not going to be shamed. Staff's not going to hate us if I say that something's wrong with me. We're not going to lose our housing. We're not going to be treated poorly. Constantly emphasizing that to the children you serve, that they can tell you if they're sad. They can tell you if something hurts, if something is sore. Parents may not report symptoms for the same reason. So we've worked with many families who kept an illness a secret. They kept a chronic illness a secret. No one knew the child was diabetic, kept all of that a secret in order to not suffer some negative consequences. And as a result, the child's health deteriorated. They may also do that to avoid losing custody of their children. And so is it safe for a parent to say, hey, my child is sick, or does that mean CPS is going to be called? And do they know that? Do they know it's okay for you to say this? There's number one fear, almost always, of families experiencing homelessness is losing custody of their children. And so every time someone's sick, every time someone got an F, every time someone missed the bus, there's this fear they're going to call CPS. So being aware of that and mitigating that. It's okay to be sick and knowing what you do have to report and what you don't. How does your program respond to physical sickness or emotional instability? Is the fact that if you have scabies and you don't do anything about it long enough, you're eventually going to get kicked out. So how can you offer support? How can you create an environment where it's okay to talk about these things and people aren't afraid? People aren't afraid that they're going to be sleeping on the street because, Junior broke his toe or whatever. But this is not an issue very often with families. It's a huge issue with families that are homeless. And so to be aware of that. So as we finish out today, I want to talk about some things that are really significant red flags. This kind of almost life or death kind of issues with children who are homeless. The first is failure to thrive. Failure to thrive. We talk about failure to thrive with newborns, and certainly that is a big issue with newborns. When I think about children in crisis, I think about this across the board. I just saw those of you that contributed in the chat, and that is awesome. Thank you so much. With different ways of keeping things clean, and I really, really appreciate the feedback. Failure to thrive, where a child, they're not growing, they're not developing, they're not learning new skills, they may be regressing, where they came to shelter and they were potty trained and now they're not, but they're just not moving forward. We see this all the time in adults, but we don't have to worry about it in as much with adults. But with a child, if you have a 6-month-old baby in shelter and they're not developing new skills, this is a huge red alarm, right? Because this is a time in their life where they should be growing rapidly and constantly learning new skills. But if they come to shelter and they just freeze developmentally, which very often happens, that is a huge red flag. And they can actually have a long-lasting impact on their overall development. So we get used to a child comes into shelter, like, okay, here's the baby, 6-month-old baby, and 3 months later, the baby looks exactly the same. The baby has the exact same skill sets, but all the staff coming and going, like, well, it's a baby. Baby looks the same. And so, is there anyone in your program who's saying, wait a minute, this baby looks the same? This baby's doing exactly what she did the day she came in, and that was 2 months ago. We should be seeing constant progress, growth, development, new skills, new words. And if you don't in children, then it's a huge issue. And it's probably not on anyone's checklist in shelter. So is the child thriving? Something needs to be done if they're not. Got to get them to the pediatrician, got to get them to be assessed, got to talk to the teacher. What are we going to do? We've got to do something. This child's not progressing. So making mom and dad aware of that, and what are we going to do? Let's develop a plan, and not ignoring that. Obviously, signs of physical neglect or abuse, bruises, scars, we would think about, obviously, but also if you have children, and this is fairly common in shelter too, but they pick up the doll and they shake the doll, they tell the doll it's bad, they beat it, they hit it. In their role playing, what are they doing? Is it aggressive? Is it dark? Now, certainly children will take out their feelings of anger and aggression on a toy very often. We had lots and lots of Playmobil families in shelter, and the poor dads in the Playmobil shelter and domestic violence shelter, just the terrible things we did to all the daddy toys. And I get that. But if specifically around their role playing something where the child, the person who would represent them in their play is being hurt, is being abused, is being mistreated, that can be a real red flag. Children who draw pictures and the children have X's for eyes, or the children are dying or being killed, dark themes in play can be a real sign of physical abuse. And so just being aware of that. I'm not saying every time someone draws a picture of a little boy in prison with X's for eyes that you need to call CPS, but this needs to be a conversation with mom, with mom or dad. This needs to be a conversation with the child. Hey, what'd you draw there? He doesn't look too happy. What's going on with him? Constantly assessing and having those things on your radar are really important. Signs of sexual abuse that would not be as obvious as some of the things that we would obviously think about. But again, how are children playing? If children are in their role playing, acting out sexual things, that should be a red flag. That should be a source of concern. It may be that they've just been exposed to movies, but even that for children is very dangerous. So if children are acting out sexually or doing things that are of a very sexual nature, a very dark nature, that is absolutely something that should lead to a conversation. If what they're drawing or acting out with stuffed animals and things like that is sexual in nature, again, that should be a red flag. That should be taken seriously. That is not normal. That is not healthy. Children that are scratching in their groin area, in their rectal area, is a big sign of sexual abuse that sometimes gets missed. The children that have a rash or that just seem to constantly be touching those areas, certainly some of that is normal. But if it's constant, then that would something, if they're touching each other in those areas, that is something, again, that can be part of normal play and normal exploration, but it's something with children in crisis and families in crisis that we need to take seriously. Bruising around the mouth or in those areas, again, should be taken seriously. And then a big sign of sexual abuse that a lot of people miss and that can be common in children who've been through crisis is to have lice in their eyelids. And I've had several children that was the primary sign, that the only way you can get lice in your eyelids, only pubic lice live in your eyelids. in your eyelashes, So children who have lice in their eyelashes, that is a definite sign of sexual abuse and should be taken very seriously, and calls should be made. So understanding these signs, being aware of them, and then knowing what your agency policies and procedures are and what are the steps that you take. That's something that we're not going to talk a lot about here because it should be mandated by your agency and you need to know what those steps are. And so volunteers who come to you and mention these things, you need to know what has to happen next. That should be something that you don't have to, well, I guess I'll have to call someone and talk to my supervisor. You need to know. If you could not explain that to me right now, what the policies and procedures are, you need to find out. Lethargy among children is a big red flag. Children who don't play, who don't get up, who are sleepy all the time. This can be a real red flag with children. When they first come to shelter, maybe, or, you would expect to see some of that, especially maybe around puberty or around youth, but lethargy should be taken seriously. Sometimes I would hear people say, oh my goodness, your baby's here in shelter. They don't cry. They're so good. They're such good babies. Babies should cry. So when babies, very often children in trauma, they don't cry because when I cry, no one comes, nothing happens. That's not good. So babies who sit in their stroller all day, every day, and they don't ever want to play and they don't make any noise, that's not a good baby. That's an unhealthy baby. So having that on your radar, having other staff that know that. If you don't see the children in your shelter all day, they're only coming home at night, and you don't have any evening staff who are really trained to know these things, they need to be. A lot of times we see this a lot in shelters where your staff that are really trained to interact with your children are only during the day. And so children who are only there at night don't ever interact with someone who knows what to look for, who knows what the red flags are. And so making sure your overnight staff know that as well. Changes or extremes in eating or sleeping patterns, self-harm and suicide. We do whole trainings on this. And so if this is something you're concerned about, we can do trainings on this. It is something you should know a lot about. But what I want to say here that sometimes isn't included in trainings in general on self-harm and suicide is that when you have a community living environment, you have a whole lot of young people living together and they're all in crisis and they've all suffered tremendous loss, whether that's in your supportive housing environment or your shelter. Things like self-harm and suicide and even homicidality can be very contagious. And so you really have to watch for this in shelter, that if one child is practicing self-harm, very often, very quickly, that will spread to all the other children who've never struggled with that before, who've never even seen it before. And so keeping that in mind, that if you have a child, a resident who practices self-harm or who is suicidal, and those are two different things, important to know, again, different training. Eating disorders, same thing. These are three different things that can spread very quickly to everyone in the environment, to all the children. And so talking about those things. We had a time in shelter where we had a young man who was suicidal. He was suicidal when he came to us. We didn't know that. But in his first week there, he stepped out in front of a bus at shelter. He was not killed. He was hurt, but he wasn't killed. Within 3 days, 4 other young people had all attempted suicide. It's contagious by nature. We could talk a lot about that, and I'm not going to, just for the sake of time, about the different mindset, the different factors there. But the fact that those things can spread very quickly is what I really want you to see as a red flag. If you have one incident of this, you need to be aware of it. Suicide games, things like choking games, where children will put something around their neck and then jump from something or slam the rope or the belt in the door or tie it to the bed. And these things too can really spread through a shelter. And I've had children. I had a young child die doing this. So things to take seriously. That you may not, if your own child, in the back seat said something, you might go, what in the world? And kind of not in shelter. These things have to be taken very seriously. And then any kinds of plans to hurt themselves or others, taking very seriously when children say, well, I would just kill him, or if you do that again, I'm going to tie you up, and take it very seriously. Again, we're dealing with children who may really be struggling to express themselves, who may feel so powerless, who may feel such a lack of control that they can do drastic things to get attention. They can do drastic things to cope, to address the feelings that they're feeling. So just being really aware of that when you think about the health, when you think about eating and sleeping and playing and social interactions and experimentation. And this is very different sometimes. Certainly don't want to make broad, gross generalizations, but very different sometimes than what your children are struggling with. So being aware of that. I want to close out today. This is my last thought, but I want to close out today with really keeping in mind that there are children that you're seeing, there are children that you're engaging, that no one else may really be seeing. And again, we're talking about children in crisis. I had we had a family come to us, and the mom, when she was 15, she was in Mexico. She lived in Mexico. She was Mexican, and she was kidnapped. She was put in the trunk of a car and driven across the border, and immediately introduced to a human trafficking ring. She was prostituted against her will. Eventually, the man who ran the prostitution ring married her, and she was removed from it somewhat. She had 4 children. But her 3rd child had severe birth defects. She actually had to be fed through a tube in her stomach. She didn't have an esophagus or something. I don't remember. I'm sure that's probably too harsh, but severe birth defects. She ran away from her husband, and she was eventually sent to the FBI and put in witness protection. It was this huge ordeal. This had been happening for 4 years. She testified. Things were somewhat better, but she was sent to our shelter as sort of a transition from this crazy witness protection, crazy chaos that she'd been in. She was sent to Tennessee. That was all in California. Stayed in our domestic violence shelter, and she was trying to transition into normal life. But when she came to us, she had 2 children. She had the little girl who was about 6 with all the severe birth defects and needs. And then she had a 4-year-old son. And they weren't English speaking. She spoke very little English. The children didn't speak any English. They'd just been living in just constant chaos. About a month after they got there, we had a volunteer come who was Spanish speaking and was speaking to the little boy, and he didn't say anything. And so we began to be concerned, eventually realized that this little boy was 4 years old. He was completely deaf. He couldn't hear a thing, and no one knew it. There had been no intervention in this child's life at all. For 4 years, he'd not said a word. He'd not understood anything that was being said to him. But their family was in such chaos that no one in 4 years, in the course of this child's life, he'd had surgery on his foot from a bike accident. He'd been surrounded by doctors. He'd been surrounded by nurses because of his sister's issues. He'd been surrounded by caretakers. He'd been surrounded by law enforcement and social workers and case managers. And this child's life had been surrounded by all these good people really wanting to help. But no one in 4 years had looked that child in the eye and spent enough time with them, including his own mom, who was also in absolute crisis, trying to keep his sister alive, right? There's not blame anywhere in the story. But no one in 4 years had looked at that child and realized, oh my goodness, you don't hear anything we're saying. Very often the families that you're interacting with have been in so much chaos and so much confusion and loss and grief and pain, just trying to keep everyone alive. And the child gets up and they eat and they get dressed and they do all the right things. And so we all just think and hope and assume they're okay. And so I say all that to say that you may be, this is the beauty of the job you have. This is the goodness in the job that you have, is you may be one of the few people who has the opportunity to stop and really look into the eyes, into the heart of this child and say, okay, are you all right? Are you all right in there? Are you growing? Are you developing? Are you learning? Are you eating? Are you sleeping? Are you playing? Are you okay? Is there anything in here that's really not okay? That's not on your checklist. That was the problem is for this family, no one had a checklist that said, hey, really spend some time with little brother and see if he's all right. Because he looked fine. He looked absolutely fine. that's a gift that you have and a unique position that you're in, is that you have the opportunity to stop, to look at the children that you're serving. You can teach your staff, your team, to take the opportunity to really look at the children that come through your program and really evaluate, are you doing okay? And if you're not, what can we do? Doesn't mean we call CPS. It doesn't mean we ship you off somewhere. It doesn't mean we immediately write you a prescription. Or are you okay? What do you need? What can we do to help? And as you do that, there will be children who thrive and who live and who grow and experience goodness and love and hope because you came to work, because that's what you do. So I want to leave you with that today. I think that's a really exciting possibility. I do genuinely believe in that possibility, or I wouldn't have done the work that I've done. I wouldn't be doing the work that I do. And I encourage you to think about that today, to inspire yourself with that, and also to spread that to your staff and to your team. I hope these 3 trainings have been helpful. I hope they've been something that you can really implement into your program. As I said before, we're really here to help. If there are trainings that we can provide, if there are conversations you'd like to have, please reach out. We want to be here to support your work, especially as it comes to healthcare, and then most especially as it comes to helping the families that you serve get TennCare and get the healthcare that they need. So I encourage you to reach out if there's anything that we can do to help you. We would love to be in touch. We will be doing some more of these after the holidays in the spring. And so if there are topics that would be of interest to you, I encourage you in that as well. Thank you so much for joining us today. It was so good to see the names and to be a part of your work. Have a good holiday season, and we will be in touch after the first of the year, if not before.